കിട്ടില്ലേ കിട്ടോ
ഇങ്ങനെ സ്ക്രീൻ ഷെയർ കൊടുക്കാം എന്നിട്ട് നമുക്ക് മറ്റേ സ്ക്രീൻ ഷെയർ
ഇതാണോ സിപി
ഷെയർ
ഷെയർ
വന്നു
പിന്നെ
അതിന് നെക്സ്റ്റ് ഇങ്ങനെ അടിച്ചു നോക്കുക
എന്തോ
ഒന്ന് അമർത്തി I scroll and okay, try it. No, thanks.
thanks. Need share.
What is share? Nick is English.
അത് മൂവിയില്ല മ്യൂസിക് കളിക്കണം അത്
ഇതല്ല ഇതും scroll and zoom the resolution.
ഇവിടെ വായിച്ച പോരിന് ലിങ്ക് കാണുന്നു ഓക്കെ അല്ലേ സെറ്റ് അല്ലേ
അത് വെച്ച് ഞാൻ ഇതിന്റെ സൂം ആക്കി കഴിഞ്ഞാൽ ഇതിപ്പോ കണ്ട ലക്ഷ്മി പ്രസന്റ് ചെയ്ത പോലെ ഇതാകുമ്പോ ചേച്ചിനും കാണാൻ പ്രസന്റ് ചെയ്യുന്നത്
ഇതിൽ ഇങ്ങനെ പോണോ അല്ലേ ഞാൻ അതൊരു പാടാണല്ലോ ഒരു പണിയേടാ രണ്ടെണ്ണൊക്കെ കുറിച്ച് ഞാൻ എന്ത് ചെയ്യും അല്ലേ
ഇങ്ങനെ പോവില്ല ഇങ്ങനെ പോകേണ്ടതാണ്
സ്ക്രോൾ ചെയ്യുന്ന പറ്റിയാലും പോയാ പാടില്ല ശരി എന്റെ കൂടെ കുത്തിയിടും അവിടെ കുത്തിയാലും മതി
അവിടെയാണോ കുത്തിയപ്പോ എന്താ മണി പ്രശ്നം എന്തായാലും ഇത് നമുക്ക് ഇതിങ്ങനെ ഇത് വെച്ചിട്ട് തന്നെ നമുക്ക് ഇങ്ങനെ ഇത് വെച്ച് സ്ക്രോൾ ചെയ്യണം പക്ഷെ നമ്മള് ഒരു ഇങ്ങനെ റൗണ്ട് ഇങ്ങനെ ചെയ്ത് പോയി കഴിഞ്ഞാൽ അത് വർക്ക് ആവുന്നില്ല
അതിന്റെ ഓപ്ഷൻ നമ്മൾ കൊടുത്തോണ്ടാണ്
സ്റ്റോപ്പ് ഷെയറിംഗ് കൊടുത്തിട്ടൊന്നുമില്ല അതിന്റെ മുമ്പ് അത് തീരെ നീങ്ങുന്നുണ്ടായില്ല
നമ്മൾ മാത്രമേ ഒഫീഷ്യലി ഷെയർ
ചെയ്തിട്ടില്ല
ടച്ച് ചെയ്താലും പറ്റില്ല ഉറപ്പല്ല
യൂട്യൂബ് സ്ട്രീമിംഗ് ആട്ടോ
ലാപ്പിന്റെ പ്രശ്നമല്ലാന്ന് തോന്നുന്നു
അല്ല നമുക്ക് ടച്ചിന്റെ ആവുന്നില്ലല്ലോ ടച്ച് പറ്റും വെറുതെ
റൈറ്റ് ക്ലിക്ക് ടു ചേഞ്ച് ടൂൾ
ലിങ്ക് ഇട്ടൂടെ ഗ്രൂപ്പില്
ജേക്കോ ഇതുണ്ടല്ലോ ഒരു കാര്യം ചോദിക്കട്ടെ ഇത് നമ്മള് മൗസിൽ സ്ക്രോൾ കൊടുക്കുമ്പോഴേ ഇത് മൂവ് ആവുന്നുള്ളൂ സ്ലൈഡ് മാറ്റുന്ന
അത് നമുക്ക് ശരിയാക്കാം, സമയമുണ്ടല്ലോ.
ആ ഓക്കെ, എന്നാ ലിങ്ക് ഇടട്ടെ.
ഇട്ടോളൂ. എനിക്ക് തോന്നുന്നു എക്സ്പ്ലോർ നോക്കാം.
ആ ഓക്കെ.
ജേക്കോ ഇതുണ്ടല്ലോ. Ma'am, shall we start the session?
Okay, sure, dear.
Okay, ma'am. Good evening. Good evening, one and all. I am Dr. Reshma Raj, PG Scholar, on behalf of Department of Kaumarabhrithya, Government Ayurveda College, Trivandrum, welcoming you all to the Day 3 of National CME on Cerebral Palsy. DIVYANGA, ability begins where limitations end. We already discussed the etiology, differential diagnosis, and investigations in cerebral palsy, and various case presentations on spastic and chorioadaptoid cerebral palsy. Today's session will be on the topic Management of Cerebral Palsy by Dr. Roshni Anirudhan, Professor and Head of Kaumarabhrithya. Second session about in-house researches conducted in Department of Kaumarabhrithya, Government Ayurveda College, Trivandrum by Dr. Sankita P. Shankar. Moving on to the first session of Day 3, DIVYANGA, about Management of Cerebral Palsy by Dr. Roshni Anirudhan. She completed her graduation from Government Ayurveda College, Trivandrum. She done post-graduation in Samhita and Siddhanta, and she also owns a post-graduation in Kaumarabhrithya too from the same institution itself. She completed PhD in childhood autism in 2020. She also done certification courses in pediatric advanced life support by American Heart Association and certificate program in childhood disability management. She has 22 years of clinical experience in managing autism spectrum disorders and cognitive behavioral disorders. She won Athreya Award in 2019 by Government of Kerala for her contributions in field of Ayurveda pediatrics. Also won the Best Project Coordinator in 2019 for Snehadara project. Ayurvedic Management of Developmental Disabilities in Children. She was the first runner-up of National Level Research Award 2010 in Ayurvedic Management of Cerebral Palsy. Due to some inconvenience, she couldn't able to join us now online. So instead, send us pre-recorded video on management of cerebral palsy. We will be playing that, and she will join us soon for question and answer sessions. All your queries will be addressed by herself. So please save your queries till the end of session. So we are about to begin our first session.
Good evening, one and all. Today we will be dealing with cerebral palsy management from an Ayurvedic platform. Last 2 days we had been discussing about etiology, differential diagnosis, and investigations in the management. So, coming to different presentations of cerebral palsy, the management protocol has to be tailor-made. It can be different in a spastic CP case, in an ataxic CP, choriothetoid, or mixed forms. So, this is a form of spastic diplegia where the lower limbs are involved. Spasticity is more over here, and the rukshata of vada is more, stamba sankocha is more, and an associated finding usually in diplegia is that convergent squint is also associated. So we need to have a thorough observation of the clinical features and a detailed clinical examination before going into the management plan. Again, cases of spastic cerebral palsy. That stooping gait is also very classical in that, toe walking. The left-sided picture is giving an impression of spastic CP, but that scissoring is not present over there. So in elderly kids, the chance of joint subluxation or dislocation is very common when the patient is not on regular physiotherapy. So also we have to check for that. Here in the left picture, the child is having dislocation of the right shoulder and the right hip. That is why it's not giving you a crossing picture. So usually an unprofessional physiotherapy or unprofessional caring of the child can lead to dislocations which are not that painful in normal kids. This is a spastic quadriplegia case. You can see that cortical fisting and the head holding is very difficult in this child. She's trying hard to have the head holding. So that spasm is evident over here and the head holding is only limited. So the management protocol should always include the positive elements of physiotherapy and other allied systems which we can include. So in each and every case of cerebral palsy, especially spastic ones, should be put on physiotherapy. It should be regular and parents can be advised to have it, to follow it at home as well. Again, another case of spastic cerebral palsy where the child is finding difficult to walk. Spasm is evident over there. The baby is on AFO and still with that stooping gait, he is having the support of the walker. This is a case of ataxia. You can see that spasm is not evident over here and that ataxic gait or the floppiness is dominating here. Actually, through these videos, I wanted to picturize the difference in the muscle tone and difference in the level of thoracic involvement in these different types of cerebral palsy. Here, spasm is totally absent and floppiness is overpowering. Slaghangada, Gatra Gaurava, Sandhi Shaidilya. All our kapha lakshanas are dominating over here. Here, spasm is not there. That involuntary movements or dystonia is overpowering here. See, that dystonia is overpowering here.
Okay. Come on.
So I was trying to summarize that in different types of cerebral palsy, we need to see the difference in muscle tone and also difference in clinical presentation. Next point we should bear in mind is the common associations with cerebral palsy. Very rarely a CP case presents you without any association. Usual associations are seizures. Many a times it's like that seizure is more dominating than the cerebral palsy manifestation. So while framing a management protocol, the association should also have enough consideration. Mental retardation can be found in usually quadriplegic CPs or ataxic types, and that should be evaluated separately. Hearing defects should be screened for, especially in choreothetard CP. Cerebral palsy, usually due to hyperbilirubinemia or exaggerated kernicterus, is usually associated with the choreothetard CP with a sensory neural hearing loss. So whenever you see a dystonia or a choreothetosis, make sure that the baby is hearing well. When usually hearing defects are associated with speech and language defects as well, so it's better to go for a BERA, brainstem evoked response audiometry, for a hearing evaluation. Visual defects are associated when investigations like VEP can help you. Speech and language defects like dysarthria, scanning speech can also accompany. Emotional disturbances, though not that common, can have an association, like cognitive behavioral disorders can be associated. Learning disability, drooling, which is the usual complaint in CPs, and recurrent respiratory infections, usually in kids who are bedridden. So we should have a management protocol for these associations as well, which is not compromising or which is not contradicting the usual management protocol. Contemporary medicine is having or putting forward physiotherapy as the only management strategy. So it should be practiced as early as possible and as continuous as possible, because withdrawal effects are more with physiotherapy. It should be regularly practiced in kids. And it's not that baby friendly as well, especially in cases of spasticity. It's a bit painful also. So it's a skill of the mother or the therapist to implement the physiotherapy in a baby friendly pattern and continuously, so that it can prevent contracture of the joints. Occupational therapy has been incorporated in attaining the activities of daily living, and play therapy also more popular nowadays, as it's more baby friendly than the physiotherapy. And the role of assistive and adaptive devices like splints, cast, and calipers are widely used, which can be well incorporated into our therapies as well. Veshtanam is one among, comes under the Vadavyadi Chilsa as well. So to have a deep knowledge of this role of other management therapy techniques like physio, OT, play therapy, and these devices, tomorrow's class by Dr. Arathi will help you a lot. So I won't be going in detail about these devices, but we should have a base knowledge regarding this, whether to use or not to use. Other drug options are also available in contemporary medicine for reducing the spasticity, like Liafen, Baclofen, and all. So sudden weaning of the drug can precipitate the spasticity in patients. And many times patients come to you after having a motor nerve blocks. Nerve blocks are usually advised when the spasm is more, especially in adductor spasm, popliteal spasm, and Achilles tightness more. Peroneal nerve blocks, or the nerve root is traced, and usually botulinum or phenol is used as a nerve blocks, which are actually causing a local damage to the nerves and thereby trying to reduce the spasticity. Surgical practices like Achilles tendon lengthening is widely practiced, and even posterior isotomy is also not that rare now. Physiotherapy can be well incorporated, which will be dealt in detail in tomorrow's class. This kinesiology taping is another technique which can be well incorporated into our management protocol. Need to know that where to tape and how to tape. It's widely available in the market and not that costly. Different strength of kinesiologist tapes are available, starting from blue, and the color code is given. And each color code denotes a definite strength of that. So depending upon the laxity of the muscle or the joint, we have to plan the stretches. The taping technique can be adopted. These are the different taping techniques, especially in the lower picture. It's a cerebral palsy child with poor head holding. So increasing the spinal muscular strength with taping can be adopted into our management protocol. A shoulder dislocation or a drooping shoulder or a popliteal stiffness can be managed with taping along with our therapies. Basics of occupational therapy can provide a baby-friendly atmosphere for efficient physiotherapy to be implemented and help them to achieve that ADL very fastly. Transcutaneous electrical nerve stimulation or TENS is widely used in the management of CP since long years. Actually, the nerves are being stimulated in a lower level with very micromillivolts or millivolts of current. So usually it's a baby-friendly procedure, and kids do cooperate with that. So it can reduce the spasticity to certain limits and also prevent the contraction if done in a professional manner. These are hydrocollators. Hydrocollators are actually heating pads. The spasticity can be well controlled with hydrocollators. Actually, it's a way to give a tabasveda. These hydrocollators are available in different types and sizes, which can be dipped in hot water to attain a specific temperature and then kept over the body part where we need a sveda. This can be well incorporated with the Upanaha treatment protocol in our Ayurvedic stream, where in Upanaha we need to maintain that temperature of the Upanaha Dravya constantly for a longer period. So usually when we tie the drug alone, it's not that possible for longer periods. So what we can do is use a hydrocollator and wrap around the Upanaha so that heat can be maintained for longer duration. This is IFT or interferential treatment. This is again another form of electrical stimulation, which is widely used by the physiotherapists. Orthotics, this is an AFO, usually used in cases with spastic cerebral palsy or spastic diplegia, so that an increased dorsiflexion ankle or dorsiflexion or toe walking is prevented in the child. This is the procedure of Achilles tendon lengthening, not to be discussed in detail in this session, because we need to know the complications of tendon lengthening and how it is being done, so as to plan tailoring our therapy in cases who had done this ATL. This is motor nerve blocks injecting into the motor points of the involved muscles for reducing the spasticity. Actually, it's very damaging that nerve, blocking the afferent. And very rarely, efferents are also blocked. So neurolytic blocks are usually used. Phenol is cheap and widely used, and nowadays botulinum is also used. So after giving a nerve block, it's advised for intensive physiotherapy for the next 3 or 4 months, or plaster Paris bandaging is also advised for that kids for a period of 1 month, so that that spasticity or that tightening can be reduced. By the time that nerve block is fading off, the child should be actively increasing the muscle power of that specific joint and should attain that increased capacity or power of the muscle. That's the aim of the nerve block. Usual duration of a nerve block is like 6 months or so. So it's a temporary release of that spasticity by damaging that nerve. This is another recent trend in the management of this non-ambulant kids. This is unway mobility. Those who are not attained walking, this is the training protocol. The kids are wrapped in that pullover bag, and the weight can be adjusted in that weighing mobility machine, and we can nullify the weight of the child by equating the child's weight with that uplifting weight. If the child is having a 16 kg and he cannot put into walking, so we can adjust that weight of the machine, like equated to the body weight, like 16 kg, so that the machine will be pulling, that hydraulic machine will be pulling the weight of the baby from up, so that baby can be put, or the child can be put in the walking or straight posture, and the child won't be feeling his body weight. So it can be easily used for walking training, especially when the child is unable to stand even with support. See,
open your legs.
Now the full weight is pulled
move
up,
forward.
so the child is made to walk
More.
with the F4 on the lower on the ankle,
Ahmed. Move forward.
and this unway mobility machine can be
More. Move forward.
used in walking.
Pull the walker. Yeah.
Slowly we can reduce that weight like by like 1 kg or 2 kg, so that the child will feel like he's walking
More, Ahmed.
with
Walk. Walk.
a body of 1
Yes.
kg weight.
Open your legs. More. More. More.
Usually the kids feel more confident and they learn to walk fast with the help of these techniques. But we should realize that these are only symptomatic treatments, and the underlying brain pathology is not being managed in either of these therapies. So a neurodevelopmental development is not being happening in any of these therapies, which I mentioned now, either in physiotherapy or these calipers or assisted devices or nerve blocks. So it's just a symptomatic management of spasticity which is happening. So the prognosis is bleak as far as we are not addressing the neurodevelopment. Here comes the importance of Ayurveda, which has a potential in managing the neurodevelopment as well. So an Ayurvedic review. I won't be going into detail because last classes were dealing with the details of this etiology and everything. So I am just brushing up to make a base for this management protocol. So we should view it as a condition of Vadottara Sannipada Roga, because Dhadukshaya is involved in each and every case. Brain damage is inevitable over there. But even though Vada is dominating, associated doshas vary in each type, which we will discuss in detail. Affecting the Madhyama Roga Marga, with Shiras as the Rogadhisthana, and Vyaktisthana being the Sarvakaya in types of quadriplegic CP, ataxia, choreothetosis and all, while it's only Adakaya is involved in diplegic CP and all. So management strategy should be framed incorporating the Vada Vyadhi Chikitsa, definitely, but we should know that we are not supposed to directly enter into a Vada Vyadhi or Brahmana Chikitsa, because this disease has afflicted the child in the early phase of development. Even from the intrauterine phase, the baby is being involved. So that development of all the dhadus has been hampered with this disease. So the dhatu poshana is not is happening in a good level. So it can be considered as a disease which has hampered the proper dhatu development. So Kashyapacharya has given elaborate description of Vakaroga, where the developmental milestones are getting delayed in a child. Only Acharya Kashyapa has given that elaborate description. No other classics have put forward a disease which is affecting the development of the child. But while describing the Vakaroga, many a times the reasons are being pointed towards that defective nourishment or undernourishment. But in the case of Vyadhija Vaka, Acharya is clearly stating that not only nutrition, many of the Nija Rogas or Agondu Rogas like Jwara can cause a defect of the child and can lead to development delays. So the treatment plan is incorporating that strategies of Shosha Chikitsa as well as points of Vadavyadhi Chikitsa. So Vakaroga Chikitsa suits well in the management of cerebral palsy. And also the management of Shiromarma Abhigata Chikitsa. Because Acharya stated that Shiromarma Abhigata can lead to brain damages and lead to Pakshakada or Sarvanga Roga. So as Shiras is the Rogadhisthana, we should supposed to incorporate the principles as well. So the main points we should include will be Snehana, Svedana and Vasti. But to what extent we should do a Snehana, with what we should do, Svedana up to what level, and Vasti with either Bhupa Matra Vasti or Kashaya Vasti, depends upon the Amshamsha Kalpana of the dosha involved. So trying to elaborate that Amshamsha Kalpana, in a case of spastic CP, spasticity is the main feature. If the spasticity was tackled, that baby could develop a bit more fast. So Rukshada of Vada is more over there. That's Sankocha, spasticity is more with Vada Prakopa, and this Sankocha is attributed to Snayu Kandara Vigar. And contractures are more in these kids. Stabdada Arujam, Prasarana Kunjaniyo Pravurti Sa Vedana. Stabdanka Ruja is a Vadakoba Vikara, especially in Majagada Vadakoba. And Prasarana Kunjaniyo Pravurti, painful Prasarana Kunjana is in Sandhigada Vada. Contracture is not the initial picture, as you all know. Contracture develops only when we are not carrying the baby in the proper way. It's a complication actually. So involving the sandhis is later happening in uncomplicated cases. Scissoring, toe walking, croucher's gait, everything can be taught in the level of khanja, pangu, kubjata and all. That rounded vertebral column in the level of kubjata. Again, vada is attributed over the affecting the snayu sira kandara. Clonus is very common in severe spastic cases. Sandhya, kunjana, kampana. Again, a vada prakopa feature in narrated in Sarvanga Vada. Opistotonic posturing, which is common in quadriplegic CPs, increased startle reflex, can be taught in the line of ayama affecting this snayu. So, I was trying to summarize that spastic CP is having more involvement of Vada and Rukshata of Vada is more over that. So spastic CP will be will suit for a treatment which will tackle the Rukshata of Vata. So the treatment package should be having Snigdha, which counteracts the Rukshata of Vata, and Ushna, because Vata is Shita, so it's Ushna Kami. So the treatment principle should be Snigdha and Ushna. So all Svedana therapies or Snigdha Sveda can be taught in spastic CP cases, which will be relieving the condition and also enabling the baby to have more developmental milestones. So to summarize, the spastic CP is Snigdha Ushna Kami. Ataxic CP. Ataxic CP, the floppiness is dominating. Gatranam Sadana, Hamani Shaithilya, Gaurava, Gurugatrata, Vak Swara Graha, that scanning speech, Bela Varna Pranasha, or Guruta Sarvagatrana, told in Kapavrata Vyana Lakshana. Stabda Gatrada in Kapavrti Lakshana. Guru Gatrada in Kapavrata Udana Lakshana. Everything need to be taught in ataxic CP, where floppiness is overpowering. Gatranam Sadanam actually comes as the lection of Majakshayam. Hamani Shaithilyam in Ojo Visramsa Lakshanas. Guruta Sarvagatrana is Siragata Kapha. So, the dosha involvement and the thadu involvement should also be we have to bear in mind. The muscle weakness or balakshaya, bele indriyopakada, can be taught in the line of pranavrta vyana in majjastigada vadavikara. Bele indriyopakada is vadavritti lakshana. So everywhere there is an involvement of kapha and vada here. And the kapacha lakshanas are actually overpowering. Hyperextensible joints is Ludhangata, Kapavrti again. Ataxic gait is Skalidam Chagadau Prisham, Skapavrta Vyana Lakshana. So on Avarana Vada, with dominance of Kabaja features, are seen everywhere. Slurring of speech is Gadgada Vaktvam, Pranavrta Samana Lakshana. So, in ataxic CP, either it gets an association with Kapha and Vada, Kapha Vadika Vigara, or mostly in extreme floppiness, it's Kapha Avarana Vada. So, the concept of Avarana should be incorporated in the management of ataxic CP. So, I was trying to say that in spastic CP cases, we can directly go for a Sneha or Sweda. And spastic CP cases are Sneha Sweda Kami or Sneha Ushna Kami. Where in ataxic CP, where Kapha is dominating, even though Vada is associated, but Kapha is having Avarana, then it's not suited to give a Snigdha treatment here. So it's better we can tackle the Kapha well with Rukshana therapies. As Kapha and Vada both are Ushnakami, certainly we can include Sweda Kriyas, but initial phases it's better that we go for Ruksha Ushna Swedas and then tackle the Vada later. Because that's an Ushna Kriya, it will tackle the Pravritta Vada as well. So ataxic CP is suiting the management protocol of Ruksha Ushna, and spastic CP is suiting the management protocol of Snigdha Ushna. Then comes choreothetoid CP. In choreothetosis, actually, we feel that athetoid, uncontrolled dancing movements, rhythmic movements, chalatva of Vada, we feel like moods. Gatra Uspurana, Gatra Vikshepa. Gatra Vikshepa happens in Pitta Vrdavyana. So the element of Pitta should be noted here in choreothetoid CP or dystonic type as well. Sarvanga Klama, again Pitta Vrdavyana. Kamba, Vada Prakopa Lakshana in Sarvanga Vada. So, Pitta, element of Pitta should be thought for. Now coming to the muscle weakness, Balakshaya, Balaindriyopakada, everything is there. Balakshaya, Pranavardavyana should be thought for in Majagata Vada. Balaindriyopakada, Vadavrti is the Gatranam Sadhanam Sandishaidilyam seen here also. So features of Ojo Visramsa and Majakshaya should be thought for. Hyperextensible joints, Ladhangada is again Kabhavrti Lakshana. So this choreothetoid CP is giving a picture of multiple dosha involvement with Pitta as well. So Tikshna Svedas, the child won't give positive results. So Mrudu Svedas, Parishegas, Pradehas will be going here. So it's a Vishama Sannipada Avastha with involvement of 3 doshas in between. And we should be aware that Pitta is also involved. So we have to tailor the treatment protocol in more judicious way in each case of choreothetoid CP. So to summarize, even though all the 3 doshas are involved in such cases where it's having its origin in early phases of development, it's a Sannipadika Roga, but the level of doshic involvement varies. As we said that spastic CP is more on Vadottara Sannipada, ataxic CP more on Kabhottara Sannipada, but mixed involvement in choreothetoid CP with Vada and Vada, Pitta and Kapha. So that was that summarizing that involvement of doshas. So as a Srodhoroda is more and the Dhatu nourishment is not happening in a good level, Srodha Shodhana should be the first line everywhere. Even though in a case of spastic CP, you are not supposed to directly enter into a Brahmana procedure. That's because we have to tackle the Srodhoroda as well. So go for Lankana procedures which are having the Srodhashodhana property as well. So internally we can go for Deepanapachana like Ashtashurna if the Koshta, and selecting the Deepanapachana is directly linked with the Koshta dosha on the Koshta. So if the Koshta is having a Kabha dominance, you can go for Ashtachurna, Hinko Ashtaga. Rajanyati Churna if, or Avipatti Churna if the Koshta is having a Pitta dominance. Padadi Gana Churna is very nice in younger kids. Vaishwanara Churna also giving good results. So Panchakola Churna, or depending upon that drug availability, you can give a Deepanapachana. But that concept of Deepanapachana is inevitable. And you should start with that protocol itself. Otherwise, that Srodoshodhana cannot be attained. And this is how we incorporate that Shosha Chikitsa protocols in the management as well. With this Deepanapachana, we are not targeting at the Jadaragni alone. We are targeting at the Tattvagni level as well. So after Deepanapachana, we should incorporate Kridas having that Srodoshodhana property also. For this Lankana Srodoshodhanatva, external Panchakarma therapies, how it can be tackled. So externally, Virukshana therapies will be providing a greater result for attaining the Srodoshodhana. Virukshana can be done with different techniques like Udvartana, Utsadhana, which we will detail, which will be we can deal in detail. Udvartana or powder massage, which we all are very thorough with. It will kindle the acne and increase the circulation and improve the muscle tone as well. And the best tool in providing is Srodoshodhanatva. It's a Ruksha protocol. So if the child is very young, too young, the skin is so slathangatva and the skin can't tolerate an Udvartana, it's better we go for an Utsadhana. Udvartana is actually a powder massage or a medicated powder massage. Another point is that if the baby is having a dust allergy or having a recurrent respiratory infection, be a bit careful while planning for an Udvartana. It's better we go for Utsadhana. So Udvartana can be Utsadhana or Utkarshana. Utkarshana is actually a powder massage itself, but with a bit coarse powder is used here, so that Kaba Shamanatva or Kaba Vilayana is more attained with Utkarshana. So in elder kids, we go for Utkarshana, which is having more Kaba Shamana, and Kaba Shamana yogas like Kotanchukadi or Tikshna powders can be used in Utkarshana. Utsadhana is actually not having that much Kabashamana as Utkarshana, but it's used especially in Vadapitta types like choreothetoid CP and spastic CP. We can plan for Utsadhana. Utsadhana is actually the churna of Udvartana, which we select for Udvartana, like Yavakola churna or Kolagulatadi churna, can be mixed with a Dravadravya and made into a kalka. Then this can be used for the massage. So as it's a Srodoshodhana procedure, Pratiloma massage need to be advised. And every time it's mandatory that that kalka is maintaining a body temperature at least 1 or 2 degrees more than the core temperature. Because it is not supposed to impart a Shita guna. It is Ruksha and it should be Ruksha as Ushna as well. So maintaining the temperature of kalka is important. Your therapist is supposed to heat that kalka in a frequent pattern and make sure that it's not causing any temperature reduction or chills during that procedure. So Sasneha Kalkena Utkarshanam is Utsadhana. The picture shown is of Udvartana, which we are very thorough with. So in Utsadhana, churna is mixed with the Dravadravya. The selection of Dravadravya can be Kashaya, Tanyamla or Takra, depending upon the condition. If you need a Kashaya, it can be a Vadahara Kashaya, can be opted for. It can be, what we use is Bala, Rasna, Devadaru Kashaya. which is widely used. So any Vadahara Patra can also be used for making the kashaya. Like Chinjapatram or Erindapatram can be used for making the Vadahara kashaya as well. So Drava Dravya can be decided upon the clinical condition. Hanyamla is a wise combination, which because that amlatva is creating the more penetrating capacity or increasing the penetrating capacity of that utsadana. So Danyamla can be thought for in the initial phases, and even you can think for takra. Prabhuda Amla takra can be thought for. Yuksha utsadana is every time without oil. You can do the utsadana and bit snigdha as a part of snigdha procedure also. If we can add a bit oil with that drava dravya, we can do it as a snigdha utsadana. So initial phase, as we are planning for Srodha go for a Ruksha utsadana, and later on, if the Srodha Shodhana has been attained better and the Kaba Vilayana is happening, and we feel that Rukshada of Vada is overtaking, at that condition we can add Sneha to the Kalka and do it as a Snigdha Utsadana. That is how we should differentiate. As the condition demands, we can introduce a Sneha. It's better not to introduce a Sneha in the initial phases. So if the Kaba is dominant, Cotton Chukadi Churna and Thanyamla or Vadahara Kashaya is the choice, my choice in a taxic CP. It's not that it's a one and only drug, but the usual combination which we follow. In Pitta dominating cases like Coriotatoid CP, Kribala HT Churna in Takra can be adopted. In Vada dominating cerebral palsy spastic CP cases, Jivantyadi Churna, told in narrated in Shoshadhikarana of Ashtanga Hridaya, where it is very nice, especially when Shosha is dominating. Jivantyadi Churna in Vadahara Kashaya is the best option. This is a picture of Utsadana being carried out in a case of hydrocephalus, having a post-hydrocephalus sequelae as spastic CP. Child is actually now presenting with spastic CP, had a history of hydrocephalus before and younger ages. So this Utsadana, this is Ruksha Utsadana being carried out. Later I will be adding Snehana along with it. So coming to Ruksha Svedas, which we are discussing now. Other many options of Ruksha Svedas are available for us, for which Valuga Sveda is the most simple and economical procedure. But the heat index of Valuga Sveda, thermal index is more, and so it should be used with utmost caution in younger kids. Though it is very useful in elder population, in adults, but younger kids it should be used with very caution. That heat regulatory mechanism in pediatric population is very limited because the hypothalamus has just started working, and the ability to control the temperature is only after 5 years. So under 5, this Pinda Sveda should be carried out with utmost caution, and especially this Valuga Sveda. Valuga is actually that sand. Valuga Sveda works well if it is added with a bit of Saindhava as well, because adding Saindhava to all these potalis will increase that penetration capacities. So Valuga Saindhava Sveda will work better than that. Busa Pinda Sveda. Busa is actually rice bran. Rice bran is having a good thermal index, and it's not that much increased like in Valuga. So Busa Pinda Sveda is widely used in pediatric practice, and Arogya Kalpadruma is advising Busa Pinda Svedas in many clinical conditions. And then Karisha Pinda Sveda. Karisha is actually cow dung. It can be used for Pinda Sveda for providing Rukshada. Then Bhasma Svedas are also indicated. Bhasma is having intense Ruksha property. So it can be used as Sveda for local, like for helping. Then comes the Churna Pinda Sveda, which is very common. Depending upon the selection of Churna, the results also varies. Then Parishega. Tanyamla Parishega, Kashaya Parishega, everything comes under that. Avagaha can also be included under that category. These are the Ruksha Svedas which are commonly used in pediatric practice. This is the Valuga Sveda, where Valuga is actually added with Saindava in cases. And when the contracture is very more and the physiotherapy is too painful for the child, then Valuga Sveda at the joints will relieve that contracture and pain. But for full body Valuga Sveda is not advised in younger kids. Rice bran is available. This is a picture I took from actually Amazon because to convey a message that this is available, easy to have purchase also. In Busa Pinda Sveda, usually the Busa taken in 200 grams along with Shigru Mula. Shigru Mula actually, or even you can plan for Shigru Patra as well, increases that thermal index and efficacy to control the Vada. So Shigru Mula, Shigru Patra is taken in equal quantity along with Leshuna and Saindava. Usually adding Leshuna and Saindava in Pinda Svedas increase that efficacy every time. So this is how Busa Pinda Sveda is carried out here. And then Karisha Pinda Sveda, not that commonly used, but it can be used by at home to use as a Pinda Sveda, at least locally in joints, which are easily available as well. Sorry. Karisha Pinda Sveda is actually the Karisha Pinda is taken, that cow dung powder is taken along with Shigru Mula and Leshuna Saindava. And special indication is in Dandabatanaka and Kalaya Khanja. It is widely used. Then coming to Churna Pinda Sveda. Everyone is familiar with this procedure. This can be done as Taba Sveda or Ushma Sveda. If the Churna Pinda is heated, dry heated, and that heat is imparted on the joint, that is actually Taba Sveda which is happening. Another option is dipping the Churna Pinda in a Drava Dravya. You can select Thanyamla or Vadahara Kashaya or Gomutra, and you can dip the Churna Pinda in the Drava Dravya, heat it, and then impart a Sveda. Then it comes as a part of Ushma Sveda. So, depending upon that doshic involvement, you can plan like that. If it's more Kapha dominant, you can go for Taba Sveda. If it's more Vada dominant or Pitta involvement is there, then you can go for Ushma Sveda as well. It can be done as Ruksha therapy, and also you can impart a slowly impart Snigdhata in Churna Pinda Sveda. So, if it's done perfectly as Ruksha, it can be either dry heated and kept on that body, or done as Pinda Sveda. Or as I said earlier, you can dip in a Drava Dravya and then do. These two procedures are actually Ruksha. But doing an Abhyanga and then doing this Churna Pinda Sveda is imparting a bit of Snigdhata. Now the next choice is dipping this Churna Pinda in oil and heating and then imparting heat. A much more Snigdhata is happening. But Shrodha Shodhana capacity of Churna Pinda Sveda need to be appreciated in each and every case. So usually before going for more Snigdha Svedas like Patra Podala, Churna Pinda Sveda is the mediocre in between. You can try that Churna Pinda Sveda in the Ruksha, perfect Ruksha as a Taba Sveda, dry heat, then slowly introduce it into Drava Dravya, and slowly introduce Taila component by dipping it or having an Abhyanga and then doing Churna Pinda Sveda. So it's a way of shifting from this Ruksha therapy into that Svetas. You can actually try for Upashaya and Anupashaya of Snigdhada while doing such alterations in Churna Pindasveta. For such, Thaila selection in such condition will be Thailas having more penetration capacities or more Srodho, Shodhana and Kavahara properties. So the Thailas used should be Eranda Thaila. Eranda Thaila is the only Thaila which is indicated in Amavada. Thaila selection where Amatva is there. Usually in every condition of Amavastha, Thaila is contraindicated. Only oil to be used with utmost caution is Eranda Thaila. No other oil is advised in the classical literature. So Eranda Thaila can be taught here. Actually, this is a crucial procedure where we are shifting from the Srodoshodhana, Rukshana to a mild Snehana procedure. Kotanchukadi Thaila, Chinjadi Thaila, Kedaki Muladi Thaila, Pinyaka Thaila, everything can be taught in this line. Here we are selecting Thaila that has having Srodoshodhana and Kabashamana properties. So Srodoshodhanatva of Thaila is very important over here. We are not selecting any Thaila having a Brahmana property here. So see for that, Eranda Thaila, Kotanchukadi, Chinchadi, Kedagi Muladi or Pinyaga Thaila can be taught in this line. The churna inside that pinda can vary. It can be, depending upon that churna inside, it can be Kulatha Bindasveda where Kulatha powder is used. It can be Sarsveda where Sarshapa powder can be used. It can be Shadakwa Bindasveda where Shadakwa Latha churna, then Kola Kulatha di churna, Kola Kulatha Jamoja Methika churna, Cotton Chukadi churna, or even Upanaha churna. Upanaha churna is available in the market. The combination is like from the yoga, Upanaho, Vajakirna, Shadakwa, Devadarubi, Tani Samaste Sagandais, Dasner and from that yoga, that drugs are selected and made into powder. And it's available. Jamoja Medika also goes in that line. Kotanchukadi is more Kabashamana. Kolakalatadi can try in Vadavyadi as well. Karpasastyadi again having more Kabashamana and Srodoshodhana. So Churna Pindastheda is actually indicated in Kaba Vadiga Vikara. And where Srodoshodhana is a mandate. Where chances of Amatva is there. It's not a protocol in Kevala Vyadavyadi Chilsa. Spastic CP cases no demand this Churna Pindasveta. Because in spastic CP cases, just after the root sadhana, you can directly shift to bit more Snehasveda procedures like Patra Podala or something like that. But in cases of ataxic CP, this Kabashamana procedure, which needs intensive Kabashamanatva, it's better that you go for Udvartana than go for a Churna Pindasveta in this pattern, in more Ruksha. And whenever you are planning to introduce Sneha also, do select Snehas like this, which are having more Srodoshodhanatva, like Kedagi Mulati, Chinjadi, or Kotanchukadi. This is Kadi Kidi. Kadi means Dhanyamla in Malayalam. Malayalam literature or Kerala literature on pediatrics, like Arabhikalpadrama, Vaidyataraga, and all Yogamrita and all come up with all these traditional alterations in Panchakarma. That is why we are familiar with the word Kerala Panchakarma procedure, Kerala model Panchakarma and something like that. Because we have a treasure of classical literature and giving a detailed description of these Panchakarma procedures. This is Thanyamla Pindasveta. Thanyamla is heated and the churna pinda is dipped in that, and then the procedure is done. Now actually it is Yuksha Ushna therapy. While we are doing with 2 pindas, the other 2 pindas will be heated. Then another procedure is just similar to Dhanyamla Pindasveda, but thermal index is much more in this type of. Here, instead of dipping in that Dhanyamla, we are heating it in steam. In Malayalam, we call it as Avi Kidi. Avi means steam, cooking in steam. See, the powder is taken in potli. As in pediatric population, we need only small pottlies. 100-gram potli is enough. Powder in a potli is enough. Potli, the way of tying the potli, I think everyone is familiar with. We are locking that powder leakage with the way we are tying it, wrapping it with the cloth itself so that it's safe. Tying with the cloth thread so that potli is tight and not loose. Potli is beautifully tight, and make sure that is tight. Similarly, other potlis are. See, this dhanyamla is taken in a vessel and it's covered with a piece of cloth and it's tight. The leftover cloth pieces are again tied in a secure pattern that it won't be catching fire. See, this is kept on the fire, and the pottery is kept over that. 4 potteries will be kept over that, so that the steam generated by the Dhanyamla or the Dravadravya, if it's Swadahara Kashaya, is heating that pottery. So here the thermal index is much more than that Dhanyamla Pindasveda, and so having more Kabashamanatva than the other one. So while we are doing with 2 potteries, the rest of other 2 potteries are being cooked and heated back. So this type of Panchakarma is providing more Kabashamanatva in cases of, so better suit for in ataxic type of cerebral palsies. Now coming to Parisheka. Parisheka, it can provide as Ruksha Sweda as well. Especially Parisheka is thought of in cases where, or if Vaitika involvement is more, then think of Parisheka. So it is in Amavastha, association of Pitta is the along with Vadakava or Vakapa Pitta. So whenever we ask the association of Pitta is the Tikshna Sweda procedures are contraindicated. But the underlying Vada need to be addressed or Vakaba need to be addressed. So Sweda, if it's inevitable, a Mridu Sweda, Parisheka is actually a form of Mridu Sweda without provoking that involved Pitta. So whenever we need Rukshana, but the skin or the dosha level cannot tolerate that much, go for Parisheka. Especially if a child is so delicate, cannot withstand Udvartana, and especially in very newborn kids and all, Parisheka is the best option for providing Rukshana therapies. Like it can be done with Kashayas, it can be done with Dhanyamla, it can be done with Akra as well. Severe joint deformities or Adisukumara Sharira, Klesha Saha, newborns, we can do Parisheka. We can do directly over the body, or for better Svedana, you can cover the entire body with a thick towel. Parisheka over that. So that skin contact with the medication is much more better. Tendency to slip into like having a chill after that procedure is also prevented if the full body is covered. Otherwise, after doing the Parisheka, baby will be feeling the too cold after remove. Otherwise, we should dry the baby as early as possible. Dry the baby and wrap it in towel. So, and also in another good procedure in premature infants and choriothetoid CP, Pythiga involvement is that. So, again, a case of post-hydrocephalic sequelae need to be managed for spasticity. So, in such conditions where this baby is too delicate to undergo an Udvartana, but we have to manage this Vada as well, then Parisheka will be there. Hope you can appreciate the scissoring in the joints. Then Parisheka will be best option. And other scenario is that when Abasmara is an usual association, then also Parisheka goes well. Here in these cases, when Shosha or Siltangada is too much, you can go for Parisheka. This is Takradara, another form of Rukshana therapy, usually done on the head, and also Ayurvedic Kerala literature advises to do in the full body as well. You can decide upon whether you are going to do it as on the head only or a full body, depending upon the disease condition. Again, Shirasnana, head bath is also important. Kalpatrima gives a detailed narration about the drug option for Shirasnana. Chances of Kapavilena is there when we are doing this Sweda karmas. If you are doing a Sweda karma, have Ruksha Swedas, do an Avachurnana on the scalp with Rasnadi Churna or Rasna Amalaki, or as the condition demands, like you can go for Kachuradi as well. Then Shirasnana is also important. If chances of Abhishyanda is there, like chance of upper respiratory or Kapavilena is the Kalpadrima advises Tushasrida Jala. That is, Tusha is actually rice bran. Water boiled with rice bran is advised for Shirasnana. And it's advised in the scenario of Jwarakshina or bronchial asthma. Amalaki Kashayam can also be used to prevent Abhishyanta. Then Acharya is advised, Kalpadrama advises to have green gram powder or Bela Patram, Mudga Churna, for washing out the oil from the head, and dusting Amalaki Rasna Amalaki Churna on the scalp. Similarly, body wash also can be used with medicated leaves and powders. Then coming to, so we had a journey through the Ruksha Svedas, now going to Snigdha Svedas. Snigdha Sveda, I'll go start from Jambira Pinda Sveda. It's actually midway. It's not that Snigdha, but not a Ruksha Sveda actually, because we are dipping in Taila and doing. But the Srodha Shodhana property of Jambira Pinda Sveda should be appreciated. This is the way we are taking the medicine. For making 2 potalis, 14 lemon is used with Leshana, Shadakwa, Methika, Krishna Tila, Kolatha, Haridra, Saindava in the provided quantities. Actually, the Taila is heated first. The lemon is cut into very small pieces and roasted along with Saindava, so that the lemon is soft and supple. Then Leshana is added along with that. After adding the Leshana, then other powders, all other powders, and mixed and dry roasted, and then mixed into. So it will be having a consistency as shown in the lower picture, and a potali is made out of that. So that is Jambira Pinda Sveda. You can think Jambira Pinda Sveda in cases where we need a Kabavada Shamana. Then the Patrapodala Sveda is there. Everyone, the most popular Sveda, even a layman is familiar with Patrapodala Sveda. Actually, it's indicated in Vadiga and Vada Kabaja Vyadis. Arogya Kalpatrima gives an elaborate description of Patrapodala Svedas, which all Patra to be selected, how to do, and all. Shigru Chinja, Chinja Arka Nurgundi, Varane Erenda Pallevei, Anierva Tatsame Swinne. It's told like that, and he has advised to add coconut scrapings along with that. So coconut scrapings to be added and to be fried when it's to such a level that when the coconut scrapings is attaining that brownish texture, then the leaves are also enough fried for and can be done as a Sveta. Patrapodala Sveta, usually Shigru, Vasha, Datura, Chinja, Nurgundi, Varana Patra, Erenda, and Arka Patra are used. If the skin is very delicate, it's better to avoid Arka Patra because it can cause big skin irritations. Usually powders like Shigrumula, Rasna, Sashaba, Shadakwa, Karpasabija, everything is added to increase that penetration capacity or vision the property of that. Nimba is also added along with that. Leshana along with coconut scrapings and Saindava. So this Patrapodala Sveda is usually dipped in Thailand, done as Sveda. It can be mixed. It can be dipped in Vadahara Kashaya as well for altering that dosha shamanatva. If you are not sure that you can impart that much nehana, you can even start with dipping that potali in vadahara kashaya or dhanyamla. And then if the baby is having ubashya, then slowly shift to taila. That will be a better option. In Yogamrita, again in Kerala traditional literature, in Vata Vyadhi Chikitsa, Pakshakada treatment is narrated like doing a Patra Podala Sweda with Erenda Patra. And Chincha Patra and Erenda Patra specifically indicated in Pakshakada management. So having that Vada Shamana property is more with that Patra. Abhabahuga management, the Tura Patra is told to be mixed with the Chincha and Erenda. So that selection of Patra is also important while doing Patra Podala Sweda. Then Haridra Pindasveda. Here, Haridra is added. It's more effective in joint, a bit of inflammatory procedures which is happening underlying, or if the baby is feeling pain somewhere of the joints, like a local inflammation, then can select Haridra Pindasveda. It is Chanjalium is being used over there. That's having more Shobhahara properties. So Shadakva Churnam, Saindavam, Haridra Churnam, and rice flakes are also added to increase the volume of that pinda. And that including egg whites in Haridra Pinda Sweda increases that Sweda capacity and that Brahmana property of that Haridra as well. You can do Haridra Pinda Sweda without adding egg white, or even you can. Actually, the egg white is poured and done in a scrambled form. So it's like scrambling the egg white along with the other materials. It's only added in the last part of that mixture. So Chanjalya is providing the Shobhahara property along with Shadakwa, Saindava and Haridra Churna. Rice flakes is adding to the volume and along with that Brahmana capacity and Shobhaharatva of egg white as well. Kukkudanda Pindasveda, or in Malayalam we call it as Muttakidi. Muttakidi is very good actually in providing, in relieving the spasticity of the joints and increasing the strength of the joint. It's this Muttakidi is or Kukkudanda Pindasveda is having bit more Brahmana property than the Patrapodala Sveda, and the thermal index is bit more increased. So make sure that while doing all these Vedas, you are having doing a tala, because Kapha Vilayana chances are more. And the use of these Kukkudanda Pindasveda should be done with utmost caution in cases with Apasmara as complication or Apasmara as an association. So here egg yolk is used. Egg yolk is the main component. That is Kukkudanda. That is egg yolk is steam cooked, and that egg yolk is taken and fried in the oil, along with adding lime, lashuna, saindava, and then churnas like Vaja, Sarshava, Haridra Churna, and then dipped in oil. As it's a Brahmana Sveda, the oil selected here is having Brahmana qualities naturally. So Karpasastyadi, Prabhanjanam, Panjasneham, Dhanvantaram can be opted over here. So we have we had a quick brush over the Svedana therapies. Now going into perfect snehanas, like Bhakya snehanas, like externally Murtha Dailas over the head, and Kayasega or Sarvanga snehana. Then internal snehana is also important in the management of cerebral palsy. The usual favorite drug combination is Kalyanaga-Krida. Kalyanaga-Krida has a potential in managing other systemic manifestations like Jwara, then Grahani Roga, and well. So it's a wonderful combination which has the Deepana Pachana properties, which can tackle the Rasadhadu Dushtis and also tackle this Vadavyadi at the same time. Actually, it also works as a detoxifier as well. So, Belyam, Mangalyam, Ayushyam, Kanti, Saubhagya, Pushtida, that other level of working of Kalyanaga Krida in developmental axis also in Divyangsha children also need to be addressed. So Kalyana Krida is actually, I advise that Krida having more Sroto Shodhana capacities and managing that Vishay garage where everything it is indicated. So that is very, it's a broad spectrum drug having a wonderful action in many of the Dhadula. Mahakalyanagam is much more Brahmana and Sannipadakna than Kalyanaka. Adding more Pitta Shamana drugs to Kalyanaga forms Mahakalyanaka. So it is not having that much Srodoshodhana effect as Kalyanaga, and it is having a Brahmana capacity. So initially it's better to go for a Kalyanaga Hakuda, it's having Srodoshodhana, and then in the Rasa, when the baby is having a Arha for the Rasayana, then it's better to shift to Brahmana drugs like Mahakalyana. Shatpala Krida can be indicated, can be used if you are targeting at Rasa Rakta Mamsa Dhadus. And Indugandha can also be thought for. That involvement of or presence of Avakshara is actually in a classical marker in Indugandha and Shatpala. If Paitiga association or Abhasmara association is there or cognitive behavioral defects are associated, can go for Kushmandaswara Sakrida or Tiktaga Krida. Bala Samarthana Krida, though not locally available in the market, it's the only drug which is indicated by Kashyapacharya. So, so it need to have an efficacy in these cases. Then comes the external perfect snehana coupled with swedana as well, kayasek. Rasatailam having a mamsarasa in the component can be used in cases with much muscle wasting. Panchasneha, Dhanvantara, Prabhanjana having Brahmana actions. So can be taught in spastic cerebral palsy cases. Sajaradi Taila is having more Kabashamana or Srodoshodhana capacities. Again, Pitta Shamana, Vada Pitta Shamana, Tailas like Shirabala, Mahanarayana, Vada, Shini, Lakshadi, everything can be taught when Pitta association is there along with Vada involvement. Then coming to Murtha Tailas. Murtha Tailas should be a part and parcel of this management protocol because birth injuries like post-encephalitic sequelae, cerebral palsy need to be addressed with Murtha Taila because Shiras is the Rogadishtana as well. Apyanga Sega Pijavo Vasti is that schedule which Acharya gives. Uttarottaram Gunadikya. So Apyanga is Sega is having more potency than Apyanga, Piju more potency than Sega, then the Shirovasti is supposed to be most superior. But in clinical practice, I do feel that Shirodhara is having more potential than the Shiropiju. Maybe that it's my individual observation. But Shirodhara is more having the complications or Kabavilena chance is less in Shirodhara than in Shiropiju. Maybe the constant snehana or constant contact with the thaila is there in Piju, and that movement of the thaila in Shirosega in Shirodhara is maybe causing that increased clinical results. Selection of oil for this Murtha Taila is very, very important. Because which dosha we are planning to tackle. Srodoshodhana and Kabashamana properties. So the drugs in the Taila should be having Ruksha property. Ruksha Ushna property. So drugs like Nirgundyadi, Asaneladi, the Turapatradi, Arimedadi, or Vajalashanadi can be thought for. Or drugs like Lakshadi, Balaguluchadi, Asana Manjishtadi, Tripaladi can be sought. Actually, the decision of head oil application is very complicated and need to be discussed in very detail. As it's bound to take much more time, I am skipping over that. If it's more vata dominating diseases like spastic CP, we can go for snigdha, drugs having snigdha ushna guna. If pitta is being associated, like Vaitiga Vigara is associated, go for Thailas having snigdha shida gunas. If Abasmara is a complication which is usually found, then don't go for snigdha ushna Thailas. Then snigdha shida Thailas like Shirabala, Shuddhabala, Arukaladi, Chandanadi, Bala Tailam, Mahanarayana Tailam, etc. should be thought. Don't go for too much Brahmana like Snigdha Ushna Tailas. If it's a perfect spastic CP without any Pitta Vaitiga association, it's clean without any complication, go for Snigdha Ushna or Brahmana Tailas like Prapanjanam, Prasaranyadi, Mahamasham, Karpasastyadi, Dhanvantaram, like that. That is how we select for the oil. This is a usual protocol of Shirodhara, which is carried out. And certain kids, they will be afraid of the Shirodhara pot being hanged from above. If that much fear factor is there for the child, you can make an arrangement of the Dhara pot to be kept aside and attached with a small tube, so that the tube is letting the oil pour on the scalp at a fixed level. Because many kids are having that fear factor for a pot hanging above the head. So that should be tackled as well. Shiro Piju as a very baby friendly procedure. It can be done even at home as well. Shiro Vasti need to be done in elder kids. Then comes the Talam, Shiro Lebam, Shiro Upanaham and all. Talam is actually that micro emulsion of that churna in Dravadravya. So that solubility of that churna is made more available, and that micro emulsion capacity of that cutaneous drug delivery is incorporated over here. Usually in Kalpatruma, when a talam is said, that it will be having three components. A churna will be there, a dravadravya will be there. If it's a ruksha talam, it needs a churna and a dravadravya which is having ruksha properties, like a nimbuswarasam or a dhanyamlam or a shigruswarasam or something like that. A swarasa and a churna can impart that kabashamana and kledahara, jwarahara properties. And a talam can be snigdha as well. Then it contains a churna and a taila. Many a times it can be a combo of three, a churna, a swarasa and a taila. It can also happen like that. So which talam to use is depending upon the disease condition. If it's Kevala Vadiga Vigara, a simple taila tala can also work well. Dhanvantaram 41 or 101 to be just applied on the scalp can also work as a tala. If you are afraid of Kaba Vilayana, then Dhanvantaram Rasnadi talam, which is very common, can be applied. If chance of respiratory infection is more, Eranda taila tala, Nirgundi Erandam or Nimbamrada Erandam with Rasnadi talam goes well. Similarly, depending upon the condition, you can alter the talam which is used. Anyway, the efficacy of talam should be addressed during the treatment procedure. The penetration capacity and the efficacy of talam is need to be actually appreciated more in the Ayurvedic fraternity. So, regarding now, after coming to the talam, now nasya. Nasya, Pradimarsha Nasya should be incorporated in the management protocol. If the child can tolerate Marsha Nasya, that should also be incorporated. Usually the Paga of Nasya is Mrudupaga. The availability in the market is very limited in Mrudupaga. Many of the other Taila can also be used as well. So, Dhanvantara Taila is widely used in spastic CP management. Kshira Taila, Baila Taila is used when Paitiga involvement is over there. If the condition is more Kapha dominant, you can go for Varanadik Kshirakrita, like that. Then comes the Vasti in the management protocol. Matra Vasti is actually when Kevala Vata is the Snehana is the protocol or Brahmana is the protocol, then Snehavastis or Matravastis will be enough. When Kashayavasti is indicated, though Kashayavasti is told for tackling the Vada dosha, it's not actually tackling the Vada dosha. Kashayavasti is actually tackling the Avarana Vikaras. Vada Vyadi due to Kapha or Vada Vyadi due to Paita Pitta Avarana is being tackled with Kashayavasti. Thereby, the Vada is also tackled beneath. When the Avarana is tackled, the Vada will be better. Vada involvement will be better. Vada Koba will be managed. So, Snehavasti is actually tackling that Kaduk Vada Vikara. And Kashayavasti is tackling that Avarana Vada Vikara. That is how it comes. So, this is one word answer is only for beginners. Please, other experts, please excuse me. Because Kashayavasti, that Yogavasti protocol is a mix of both. Because we need to tackle that Avarana dosha and make sure that there is no Vadavarti in that. So that's why we mix in a Kashayavasti and then a Matra Snehavasti and then a Kashayavasti, like that. So that's a fixed protocol which can tackle that dosha involvement very nicely. So for Snehavasti, Dhanvantara, Sajaradi, Vastitaila, Pipalyadi, Vastitaila are the drug options over here. Pipalyadi is having more Srodoshodhanatva than this Dhanvantara and Sajaradi Vastitaila. So naturally, Pipalyadi will be the drug option in Kabaja Vyadis, which can tackle the Udavarta also very well. The other two are more on the Brahmana aspects. Kashayavasti, Dvipanchamuladi Kashayavasti, Madhu, then Mustadi Rajayavanavastis, Vaidaranavastis, everything is done in different aspects of dosha involvement. Shirolepa need to be done only if Paitiga involvement is more dominating. Otherwise, Shirolepa need not to be a part of cerebral palsy management. But in cases which more Paitiga involvement or association with Pitta, Shirolepa need to be thought of. This is another procedure, we call it as in the name of Sannikiri, where this Shirolepa can be done continuously on the scalp. This is more effective than the other traditional Shirolepa. Here, we can use Kabashamana drugs as well. This is done with Shirobanaha Churna. This is not Pitta Shamana Shirolepa which is going on. This is Shirobanaha Churna which is taken, mixed with Thanyamla and then continuously done over the scalp on a specific lukewarm temperature. So it's a way of doing Svedana on the scalp. Can be done like this also. Again, the Shirobanaha Churna is made into potali, dipped in takra, made in a lukewarm temperature and then done on the scalp. Shiras is Asvedyanga, but the Rogadhisthana is Shiras, and if it's Vada Kava dominant, both Vada and Kava both are Ushnakami, so that is why we are making planned to make a Sveda on the scalp, but knowingly that it's a Asvedyanga, all precautions should be taken in that regard. Similar is the concept of Shiro Upanaha. Again, its Upanaha is a Sveda to be done on the scalp in Vata Kabaja Vyadis. So make all precautions knowing that it's an Asvedyanka, then do. Upanaha Churna can also be used in for doing Shiropanaha. Vacha Shadakwa Devataru, that yoga can be used very well. Or you can tailor make that combination according to the need of your need. While doing an upanaha, it's mandatory that half of the powder should be dhanya. Dhanyas having that svedana property should be selected. Then the other half should be the dry powder. CHT, everything can be powder, and half quantity by this powder and the other half by the trinadhanya. Mashayava and trinadhanya. Then a medium can be either takra or dhanyamla can also be used. And better to cover it with Eranda Taila because it's having that Vatashamana properties and Svedana properties. This is how Ubanaha need to be done. The consistency of Ubanaha should be like a thick consistency so that it shouldn't be oozing down. And that thickness also, the heat is maintained. Upanaha has a very wonderful result in managing that Kaba Vata Shamana on the scalp. So it can create actually much clinical results. Then usually the cerebral palsy is associated with convergent squinting and with visual defects as well. So the Netra Tarpana can also be thought in such cases. The usual market options are Jivantyadi Tarpanakrita and Shadakwadi Tarpanakrita. Then speech defects are usually associated. So Asya Pradisarana should also be incorporated in such conditions. Kalyana Valeka Churna is the best drug option over that. Mananasya in cases where Kaba association is too much, or when intellectual disability is associated in conditions. Then controlled physiotherapy, as we discussed earlier. So this is a picture of Ubanaha, which should be indicated in conditions where joint stiffness is much more. It's a very baby-friendly procedure and it's having very wonderful results. So similar the way as we had prepared the Upanaha Churna, these need to be taken, made warm, can double boil it and make warm, and to be applied on the joints which spasticity is more. Then wrap it with, usually we wrap it with Eranda Patra or something, which can contain the temperature, and then again wrap it with an elastic crepe bandage. That's how Banaha is done. Usually try for any skin irritations as we are doing in babies with tender skin. If no skin irritations are there, you can maintain that Banaha bandage for 4 hours or up to 8 hours, depending upon the condition. The joint spasticity and that joint stability will be attained more with local Upanaha. This is Upanaha on the leg with popliteal contracture, having Upanaha and then tying that knee immobilizer over that. So it's like a way of incorporating both the techniques of Ayurveda and that calipers and cast incorporated in the treatment, so that Ubanaha Dravya is maintained in that correct posture, and also the knee is being extended over that. So the efficacy of Ubanaha is more over that. You can try in that level as well. So management, so I was trying to have a brief sketch of the management protocol of cerebral palsy, what we do in our department. And I'm so sorry that I am sharing the recordings with you, because I am here at Nasik for attending that national seminar on pediatric development disorder management. So that's why I'm doing it as a recording. But hope I can be with you directly for the Q&A sessions. So we'll be extremely happy to clear your doubts and have a discussion. If you can share your experience regarding the cerebral palsy management, it will be our pleasure to hear from your part as well. So thank you one and all for the patient here. Thank you.
Thank you, ma'am, for a truly engaging and insightful presentation with a treasure trove of informations. Now, the session is open for discussion, and delegates are invited to unmute themselves to ask questions or submit their queries in the chat box. Good evening, ma'am.
Good evening.
Ojaswini Reddy raised hand. You can unmute yourself and ask directly to the ma'am your queries. Dr. Dhananjay Deshmukh raised a hand. You can unmute yourself. Ma'am, there is one query. Please explain about Shiropanaha.
Sure. Shiras is actually an Asvedhyanga, and it's mentioned that any Svedas are contraindicated over Shiras. But we should consider cerebral palsy as a special condition where that Shiras is the Rogadhisthana, and the overpowering doshas or dominating doshas are either Vada or Kapha dominant. And if there is no Pitta association, and if it's like a case like spastic CP or an ataxic CP, where there man make sure that there is no Pitta association, like no epilepsy, complications like epilepsy, or no cognitive behavioral disorders having a Paitika component, the patient should be with Gadishta. But at the time you should consider that it's an Asvedhyanga. But the disease is Svedakami. So, under very strict supervision, Sveda can be done on the Shiras. We are doing Shiropanaha in cerebral palsy cases for the last 15 years. Shiropanaha Churna can be tailor-made as per the condition, or you can just go for Upanaha Churna, which is available in the market. While selecting for the drug, it should be 50% should be on the Dhanya, and the rest 50% can go for Svedana Dravyas. We can mix it in Takra. Prabhuda Amla Takra is preferred. So what we make is, we use Musta Takra, make and dip the powder of Ubnaha Churna in Musta Takra for 1 day and keep it for the next day, so that it is Prabhuda Amlada is attained. Then after the next day, after making it and solid condition, solid consistency, it is double boiled in a vessel. Make lukewarm. That is, the temperature of the Upanaha Dravya is at least 1 degree more than the core temperature, and it's applied on the scalp after doing Abhyanga with the Kabahara oil. Applied on the lukewarm temperature on the scalp and covered it with Erandapatra. That is how Shiropanaha is done. The duration of Shiropanaha is maximum like 1 Muhurta. And preferably, it should be followed by a Pratimarshanasya. That is how it is done.
Ma'am, there is a question from Dr. Balasri Arjivan where Sanikiri is mentioned.
Sanikiri is not mentioned in classics. It's a clinical experience which we are doing this procedure for last 10-15 years. It's not in classical mention. As like that efficacy of Shiropiju and Shirodhara, we do recognize that movement or motion of the continuous movement or lepa of the drug is having more clinical efficacy than the Shirovilepa when the medicine is being stagnated. So that we have tried since last 15 years and we have recorded many cases, and that's how it's widely used in our clinical practice.
Yes, ma'am. There is one more question regarding Sanikiri. The question is, what are the other conditions where Sanikiri can be done and which all drugs has to be used?
The conditions where Sanikiri can be done and which drugs has to be used. It is like it's like a procedure of continuous application of medicine. You can do it in a Vata Pitta Shamana protocol where you can use Sita Dravyas for that. Then you should be dipping it in Vata Pitta Hara drug, like in a Balakshira or something like that. Then you can select for Amlaki or Panchagandha Churna having Pitta Shamana property. Then the aim is Vata Pitta Shamana. Then the other category is Vata Kava Shamana, when this Upanaha Churna is mixed with Mustatakra and done for Sanikiri and selected for Sanikiri. The Dravya selection is purely dependent upon that Dosha Shamanatva. Mainly it is of two types, Vata Pitta Shamana, when Shita drugs are used, dipped in Kshira, and the other is Ushna Dravyas are used in Vata Kava Shamana when it is dipped in Takra. That's the two types which you are using.
Ma'am, there is one more question regarding Sanikiri, that how Shirolepa and Sanikiri differs in its action.
Yeah. Similar to as Shiropiju and Shirodhara is different. Sanikiri is having more clinical efficacy than Shirolepa.
Ma'am,
It's not. Yeah, Reshma?
there was an interruption in between, ma'am.
Okay. The choreothetide CP and its dosha dushya status can be, I can say it. Choreothetide CP is having more Paitiga Lakshana. It is Chalavada with Pittanubandha. That Dusha is especially Sirasnai.
Ma'am, there is one more question, that is, can we use cotton chukadi thaila in spastic cerebral palsy?
Patanchakadi is having more Kapashamana properties. So there is no need of that much Kapashamanatva in spastic cerebral palsy. So in spastic cerebral palsy, it's better to go for a churnas which having bit more Brahmana properties like Jivantyadi Churna or a Kolagulathadi Churna or Eva Kola Churna will do better in spastic cerebral palsy. Patanjakadi Churna will having that much Kabashamana property will be more suited in ataxic CP.
Yes, ma'am. There is one more, another question regarding Sanikiri, that can Sanikiri be used in seizure disorders?
Sure. Sanikiri is a usual uh, hero in seizure disorder management.
Yes, ma'am. Another question is, as per Ayurveda, we recommend at least 1 hour rest after any session of treatment. Is it really needed, or can we give a physiotherapy session with a gap of half an hour?
That raspberry depends upon that Rogi Bala actually. But after every Sweda, at least half an hour rest is mandatory, because that body temperature and all vital signs need to be adjusted. So, and that also electrolyte imbalance is more possible in pediatric population. That is why after Sweda we are giving Gandharvastadi Kashayam. In Kerala, we call it as Pati Kashayam. Pati Kashayam means soon after the baby is out of Harapati, then we are giving that Kashayam. So Gandharvastadi Kashayam, it is having Dibana, Vadaharatva and Anilomana property, a beautiful combination. Usually this Dibana won't go with Anilomana, and so that Gandharvastadi is having that. And also that Anupana of Gandharvastadi is Saindavam and Madhu. Sorry, Sharkara. So, Saindava, that is sugar and salt, a combination. So, apart from this Vadashamanatva, Dibana and Anilomana, it ensures an electrolyte maintenance as well. It is an Ayurvedic ORS actually. So, it need to be given after every Sweda, especially in pediatric population. Otherwise, chances of reduction in electrolyte or altered electrolyte imbalance will be there, and a reduction in BP also will be there. So better to give at least half an hour rest for every child after that. And physiotherapy is better to be avoided after the treatment. We can do the physiotherapy first and then go for the treatment. That will be better. Otherwise, the kid will be too tired to do for the physiotherapy. And also, this oil staining will be more if we plan a physiotherapy after our treatment schedules. So the instruments used in physiotherapy actually will be stained with oil. So we usually plan for the physio first in the morning session, and then after that we plan for an Ayurvedic session. That will be actually most useful.
Yes, ma'am. Next question is that, ma'am, kindly throw some light on Rasayana Chikitsa and cerebral palsy.
Hi, Ardi. That's our alumni. And Rasayana Chikitsa in cerebral palsy is actually, it's not only for internal medications. We can plan for Rasayana starting from the Vasti as well. Mustati Rajayapana Vasti is the best Rasayana which we can provide for cerebral palsy. And then including Rasayana drugs like internal medications like Agastya Rasayana works wonders in Kushmanda Rasayana. In cases where there is no Pitta involvement, Leshana Rasayana also works well. That three we are using widely as a Rasayana category.
Yes, ma'am. Next question is that, can Pradimarshanasya help in dyskinetic cerebral palsy?
Sure. Pratimarshamasya should be a part and parcel of this cerebral palsy management protocol. And Pratimarshanasya in dyskinetic CP is also very important. We do usually with Shirabala Taila in dyskinetic CP. And even Krasna Dashmula Kruda for Pratimarshanasya in dyskinetic CP also works very well.
Next question is that, what is the treatment sequence in spastic cerebral palsy?
Treatment sequencing is like the main thread of treatment is like Snehasveda and Brahmana, but every time don't directly go for Brahmana, start with a Lankana or Rukshna, Mrudu Rukshna therapy, because planning for Brahmana, we should go for Lankana first. Brahmyastu Mrudu Langayet for ensuring this Rodashodhana as well. So start with a Deepana Pajana drug, go for Lankana procedures or Rukshna procedures like Kadikiri or Avikiri. Kadikiri will be best suit, or that is Tanyamla Pindasveda. Then slowly switch over to Abhyanga and Ushma Svedas. Then slowly going to increasing the level of Snehana, like in Patra Potala Sweda or Kukudanda Pinda Sweda. You can think for Kaya Sega in the next level. Make sure that Rogadashtana or Shiras is also addressed in between with suitable Tala, Siropiju and Shirodaras. At the end of Kaya Sega and every Svedana, it should be succeeded with a Anilomana procedure. You can think for Vasti, or a Mrudu Anilomana can also be coupled with that. Kayaseka should be followed with Vasti, Kashaya Vasti. That is the protocol. And Matra Vasti can be done as Rasayana in spastic CP management. And make sure that you are addressing that spasticity with local Upanaha and Shiropanaha as well. And after every Shiropanaha, Pradimashanasya should be followed. That's the usual things to be done, but individual alterations will be there.
Yes, ma'am. Next question is that, ma'am, can you please tell whether undergoing tendon lengthening, will it help in improving our treatment efficacy? If yes, which clinical stage we can refer for the same?
Hi, Anupriya.
Hello, ma'am.
That's
Thank
great.
you for the nice session, ma'am.
Thank you. Actually, tendon lengthening is not advised in younger kids, where we can manage the spasticity very well with our treatment protocols. But in two older kids, if that tendon is too tight and actually the success rate of our treatment is more pronounced in younger ages, and it's reduced as the age advances. So we do advise tendon lengthening only after the age of 15 if the patient is a latecomer for the treatment. Otherwise, in younger ages, we don't advise for tendon lengthening. We can usually manage it with our therapies. So older kids, if that tightness is too much, and it's crippling for the child, and that asti sandhi vakrada is causing much crippling to the child, then we advise for tendon lengthening. And before tendon lengthening, we do advise for nerve blocks and assure that whether it is giving a positive impact on the child, and then only go for a tendon lengthening. That's the usual advice we give.
Yes, ma'am. Next question is, what all DRESA preparations can be used in cerebral palsy?
I will confess that I am not an expert in managing the cerebral palsy with DRESA drugs. If someone else can help me, I'll be happy. I am not an expert in using DRESA drugs in management. So that Swarna Basma or something, very rarely I use DRESA drugs. So sorry to say that I can't help you in regarding that.
Okay, ma'am. Next question is that, how can we manage active seizure in a cerebral palsy child, like with emergency medications, when the child is under our treatment?
And the hospital I am working is having an allopathic wing parallelly along with us, who is managing the emergency conditions. Seizure management is usually well done with marma therapies, where certain marma points like Shikra marma works well in seizure management. But the possibility to shift to status
Ma'am?
Monica was there rather than... Yeah, Reshma?
There was a slight interruption, ma'am. Can you please repeat?
Sure. During the acute stages of seizure management, we do give usually marma management, where Shipra marma is usually tackled. Shipram Aksheba Maranam. So the marma is actually located in Angushta Anguli Madhyastha, this point. Shipra. Tackling the Shipra marma usually help in managing that acute manifestations of seizures. But I am working in a hospital where the allopathic pediatric wing is working hand in hand. So I usually prefer the patient care than the system of medicine. So usually for acute seizure management, I do refer the cases to that modern pediatrician where they usually advise a midazolam or a diazepam loading doses. But I have seen cases, I have seen doctors managing the seizure very effectively with Anjana therapies and Nasya. But at this stage, I am not confident to share you that you can do the seizure management very well with this, because my clinical practice need to be brushed a bit more into that level. So I thought I'll be sharing with you, which I am confident about. So maybe I can share some Anjanas and Nasyas in a couple of years.
Yes, ma'am. Any further questions? Dr. Deepthi Santosh raised a hand. Dr. Deepthi? Dr. Indumati?
Good evening, ma'am. Ma'am, please enlighten us on Shashtikashali Pindasvedam in our CP kids, ma'am. Thank you.
Sure. Shashtikashali Pindasveda is actually more on the Brahmana aspect. So it's indicated it's a usual usual selection of Panchakarma in spastic CP cases. But I don't usually do it in cases like ataxic CP where Kapha Avarna is more and where Brahmana is contraindicated.
Thank you, ma'am.
So it's not an option in ataxic CP, but it's edible. Usually I do in ataxic CPs, and in choreothetanoid CP, more than Shaktika Pindasveda, Navatanya Leba will give better results. That's what my observation is. And Shastika Shali Leba can be thought for in younger ages and Pindasveda in older ages. You can add a bit of, in Shastika Shali, you can add a bit of Mudga. It will give better results, and you can add a Mamsa also, the results are better instead of plain Shastika Shali.
Thank you, ma'am.
Any other questions to ask?
I think we are running late now. It's better we shift to the other topic, other paper. Otherwise, it's now 8:30.
Yes, ma'am. Thank you so much for spending your valuable time with us. It's a great pleasure with you.
I'm so sorry and apologize once again for that recorded session. But anyway, it's happy to have a discussion with you in the Q&A at least. Thank you for the patient hearing.
Once again, thank you so much, ma'am. Assuming all queries have been addressed, we will proceed to the next session. Now, I would like to welcome Dr. Sangeeta P. Shankar for presenting about in-house researches conducted in Department of Kaumarabhrithya, Government Ayurveda College, Trivandrum. Dr. Sangeeta completed her graduation from Government Ayurveda College, Trivandrum, currently pursuing her post-graduation in Kaumarabhrithya. She is an exceptionally talented postgraduate scholar. She has presented papers in various national and international conferences. I welcome Dr. Sangeeta.
Good evening, Monando. Now let's move to the second session of the third day of CME Divyanga 2024. Today, I'm here to present the in-house researches conducted in in the Department of Kaumaraputya, Government Ayurveda College, Trivandrum. The first study, the study titled Randomized Control Trial on the Efficacy of Dhanvantara Taila and Shiro Piju Introducing the Spasticity of Sahajatva with special reference to cerebral palsy in children up to the age group of 80 years, which is done by Dr. Sohilius under the guidance of Dr. S.K. Ramachandran, which is done in the year 2006. Moving on to the study design adopted here was therapeutic randomized control clinical trial. Study population children up to the age group of 80 years. Sampling selected randomly. Study period 41 days. Follow period 28 days. Sample size 20. Inclusion criteria cases of the cerebral palsy presenting with spasticity. Exclusion criteria epilepsy cases which under allopathic treatment. As the study was about Sahaj Jalatva, the cases with postnatal causes had been excluded from the study. And also, the cases for the study had been selected from the northern and southern parts of Kerala in order to generalize the result. Data collection. The patient data has been collected from case performer, interrogation of the parent, and the detailed examination of subject. The study tool was assessed here for spasticity, modified Ashworth scale, motor power of muscle using MRC scale, and the range of motion using goniometer, and the activities of daily living was done with Barthel score and the graded response of the developmental milestone. Intervention, the study group Dhanvantara Taila Shiropiju and physiotherapy was done. For control group, only physiotherapy was done. Moving on to the procedure, Shiropiju, Purvakarma, 2 drops Dhanvantara Taila was instilled in the ear, massage over neck and head with 5 ml Tila Taila was done.
Dr.
For Pradhana
Sankita,
Karma,
there
Shiropiju
is an
with
interruption
Dhanvantara Taila.
in your voice. Can you
While
please
statistically analysis, assessment with the grading scales has been carried out before and after, and the follow-up period of the treatment in both the study group and control group. Data analysis has been carried out with PAT tests such as
Dr.
mammography.
Sankita, there is
The
a
major
slight
findings
breakage in
was
your
analyzing
voice.
socio-demographic background, 35% where belongs to 3 to 4 years, and 13% where belongs to 5 to 6 years age group. And also, out of the total participants, 13% were male and 17% were female. On analyzing the range of movement, for the range of movement of adductor angle right, popliteal angle right and left, dorsiflexion right and left in the study group and the control group, the treatment has found effective, which was statistically significant with the
Sorry for the interruption. We will be continuing. There was slight inconvenience regarding voice modulation. We will be continuing.
Sorry for the interruption. Good evening to one and all. Let's move on to the second section of the CME, third day, Divyanga 2024. Today, I am here to present the in-house research conducted in the Department of Kaumaraputya, Government Ayurveda College, Trivandrum. Moving on to the first study, the study titled Randomized Control Trial on the Efficacy of Dhanvantara Taila as Shiropiju, Introducing the Spasticity of Sahajatva with special reference to cerebral palsy in children up to the age group of 80 years, which was done by Dr. Sohini S. under the guidance of Dr. S.K. Ramachandran in the year 2006. Moving on to the study design here used was therapeutic randomized controlled clinical trial. The study population children up to the age group of 80 years. Sampling selected randomly. In the study period 41 days. Follow period 28 days. Sample size 20. And the inclusion criteria used the cases of cerebral palsy presenting with the spasticity. And the exclusion criteria include epilepsy cases which was under allopathic treatment. As the study was about Sahaj Jalatva, the cases with postnatal causes had been excluded from the study. The cases for the study had been selected from the northern and southern parts of Kerala selected from the northern and southern parts of Kerala in order to generalize the result. Data collection. Patient data has been collected from case performer, interrogation of the parent, and the detailed examination of the subject. The study tool used here was for spasticity, modified Ashworth scale, motor power of muscle using MRC scale, and the range of motion was used goniometer. The activities of daily living was done with Barker score, and the graded response of the developmental milestones were used. Intervention. Study group. The Dhanvendra Thaira Shiropiju and physiotherapy was done. For control group, physiotherapy was only done. Moving on to the procedure, Shiropiju, Purvakarma. 2 drops Dhanvendra Thaila was instilled in the ear, massage over neck and head with 5 ml Tila Thaila was done. Pradhana Karma, Shiropiju with Dhanvendra Thaila was done. Statistical analysis, assessment with the grading scales has been carried out before, after, and the follow-up period of the treatment in both the study group and the control group. The data analysis has been carried out with pair T test, Z test, and man-Whitney U test. Let's move on to major finding. On analyzing the socio-demographic background, 35% belongs to 3 to 4 years and 13% belongs to 5 to 6 years age group. Out of the total participants, 13 were males and 17 were females. On assessing the range of movement, for range of movement of adductor angle right, popliteal angle right and left, dorsiflexion right and left in the study group and the control group, the treatment has found effective, which was statistically significant with a p-value less than 0.1. Head-to-head maneuver showed no significant result in the control group. In the study group, the treatment was also significant. The range of movement of shoulder joint and the elbow joint has showed significant improvement after the treatment in both the group. In the lower limb, the adductor angle has not improved in the study group. Head-to-head maneuver of the control group also has not improved. In the control group, the shoulder joint left, right elbow joint, and both the wrist joint has no improvement in range of motion, but all the joint has showed significant improvement in the range of motion in the study group after the treatment. While comparison of the study group and control group, it was found that popliteal angle, heel to ear angle, shoulder joint, elbow joint, and wrist joint were significant in study group than in control group. While considering the adductor angle, the study was not significant with a p-value greater than 0.05. On assessing the spasticity in both the upper limb and the lower limb, the effect was significant in study group than in control group, and the power of the muscles has significantly improved after the treatment. The grade of milestones has also not improved after the treatment in both the group. While assessing the Barker score, only mild improvements were observed within the study group, but no significant changes after the treatment on comparing both the groups. So the first study was concluded that the Dhanvendra Thailam was found effective in reducing spastic CP, also improves muscle tone, reflexes, and daily activity. Moving on to the next study, the study titled A Clinical Trial to Study the Efficacy of Selected Ayurvedic Treatment Modality in Cerebral Palsy in Children Below 80 years, which was done by Dr. Roshni Anirudhan under the guidance of Dr. S.K. Ramachandran, which is conducted in the year 2008. The study design adopted here was therapeutic and the patient has his own control trial. The study type is quasi-experimental. Study population, cerebral palsy children below 80 years, and the sample size 14. English criteria include cerebral palsy children below 80 years who were on standard physiotherapy. Exclusion criteria: CP cases with seizure disorders, recurrent respiratory infection. CP cases had motor nerve blocks like phenol botulinum. Children who underwent surgical interventions like posterior rhizotomy, tendon lengthening, and CP cases who are not on regular physiotherapy. And this study consists of the 3 phases with duration of 2 months. First one is phase of observation, second one is phase of intervention, and the third one phase of follow-up. The subjects were the subjects were divided into 4 age groups and provided with different doses in accordance with Anudi Kalpadiruma by Kaikulagara Ramavaryu. That is 0 to 1 years, 1 to 3 years, 3 to 5 years, and 5 to 8 years. Assessment criteria. Assessment of the motor development were done using Griffith's motor development chart and CDC grading for motor milestone. The assessment of disability was done with Bartle activities of daily living scoring system. And the assessment was done in 4 stages, such as at the time of enrollment, before Ayurvedic intervention, after intervention, and after follow-up. Intervention. Both internal intervention and external interventions were given. For internal intervention, Kalyana Grida with equal quantity of honey twice daily in the age group 0 to 1 years 2 gram, 1 to 3 years with 2.5 gram, and 3 to 5 years with 5 gram, and 5 to 8 years with 7.5 gram. Along with that, Rajanyadi Churna with honey given twice daily for the age group 0 to 1 years 1.5 gram, and 1 to 3 years with 2 gram, 3 to 5 years with 3.5 gram, and 5 to 8 years with 5 gram. And also Gendravastali Kashaya was given twice daily along with salt and jaggery for the age group 0 to 1 years with 20 ml, 1 to 3 years 13 ml, 3 to 5 years 45 ml, and 5 to 8 years 16 ml. Moving on to Panchakarma, the Udvartana was done with Kolapulatari Churna for the first 7 days. After that, Shirobiju was done with Dhanvantari Taila for 1 hour daily for 41 days. Along with that, Abhyanga was done with Dhanvantari Taila for 14 days. At the 22nd day, the Kayasika with Dhanvantari Taila for 7 days was also done. After that, Mrudu Vilejana with Gandharva Eranda were given according to the age, such as 0 to 1 years were given 5 ml, 1 to 3 years were given 7.5 ml, and 3 to 5 years were given 10 ml, and 5 to 8 years were given 12 ml. After that, the Payadikrama were followed. And after that, Ubanaha Sveda with Kolakulathari Churna for 7 days, and Shashtiga Sleba done for 7 days. After this, Pradhimashanasya with Dhanvantari Taila 41 Avarti was done with the above procedures. Then Matravasti with Dhanvantari Vasti Taila was also done according to the age group. That is, 0 to 1 years were given 20 ml, and 1 to 3 years were given 13 ml, and 3 to 5 years were given 14 ml, and 5 to 8 years were 45 ml for 7 days. Moving on to the discussion part on analyzing the socio-demographic data, the first one is age. Out of the total participants, 12.5% were belongs to 0 to 1 years, 35 were belongs to 1 to 3 years, 22.5% were belongs to 3 to 5 years, and 13% belongs to 5 to 8 years. And the term of pregnancy, out of the total patients, 2.5% were under the gestation period less than 28 weeks, 7.5% were the gestation period 28 to 32 weeks, and 13% belongs to 32 to 36 weeks, and 16% belongs to 36 to 14 weeks. And by considering the type of CP, 57% patients having spastic CP, 10% having ataxic, and 10% having athertoid, 2.5% having hypotonic, and 20% having mixed. Birth weight, 2.5% were having less than 1.5 kg, and 75% having the birth weight between 1.5 to 2.5. 20% having the birth weight between 2.5 to 3.5, and 2% is having greater than 3.5 kg. Modern etiology, out of the total patients, 22.5% have antenatal etiology, 32.5% have natal etiology, 20% have antenatal and natal, 2.5 have antenatal and postnatal, 2.5% have natal and postnatal. On assessing the muscle power has improved significantly with the p-value less than 0.0001 after the intervention. But after the period of physiotherapy and after follow-up, no statistically significant improvement had been observed. Hypertonicity. Muscle power has got improved after the duration of treatment, which was significantly statistically, but after the period of physiotherapy, no significant changes were obtained. The motor development milestone. Changes in the motor development milestone were highly significant with the p-value less than 0.0001 after all the phases of study. First phase, lesser set value, which denote lesser efficacy of physiotherapy alone. And the second phase have highest set value, which denoting the effectiveness of the intervention along with the physiotherapy in improving motor developmental milestone. The third phase also showed sustained improvement with high set value and the p-value less than 0.0001. Improvement has also been noticed using CDC scale, which were also statistically significant. Then on assessment of the daily living, the first phase, no statistically significant improvements were observed. After assessing Ayurvedic intervention phase, highly significant changes in the disability stage of the child with the p-value less than 0.0001. So the study was concluded as the selective Ayurvedic modality was effective in relieving signs and symptoms of CP in children of the age of 8 years and found to be superior to the conventional physiotherapy. Moving on to third study, the effect of Mahamasha Thaila internally and Mahasaindava Thaila externally in spasticity in children with cerebral palsy, which was done by Dr. S. Asha under the guidance of Dr. S. K. Ramachandran, which is done in the year 2012. The study design adopted here was single-blinded randomized control trial. Study population, children of the age group 2 to 12 years diagnosed with the spastic cerebral palsy. Sample size 24. Sampling technique, random sampling. Study period 2 months. The follow-up period 16 days. Inclusion criteria, children between the age group 2 to 12 years with spastic cerebral palsy. Exclusion criteria, spinal cord lesion, trauma, multiple sclerosis, other developmental disorders, and cognitive disorders. The study tool used here was for spasticity, which was assessed with the modified Ashworth scale. The range of movement assessed with the volumeter. Moving on to the intervention, the study group was given Mahamasha Thaila internally in the divided dose of 2.5 ml for children of 2 to 6 years age and 7 ml for children of 7 to 12 years age. External application of the Mahasaindava Thaila for 1 month period was also done. And in control group, only the external application of the Mahasaindava Thaila was for 1 month was done. The statistical analysis. Qualitative variable, chi-square test and Fisher's excel test were used. Quantitative variable, t-test and the Mann-Whitney u-test were used. Then comparison of the data, the paired t-test and the Wilcoxon sign rank test were used. On major findings, on socio-demographic status, 62.5% belongs before 6 years and 37.2% belongs 7 to 12 years. Out of the total participants, 66.7% cases were male and 33.3% cases were females. The comparison within the group, first one is muscle tone, which is improved statistically in the study group and in control group, which is significantly improvement has occurred both after the treatment and after the follow-up period with the p-value less than 0.001, except in the right upper limb and left lower limb. Then comparison between the group, while comparing two groups, it is found that improvement in the study group was higher than the control group except left upper limb, and more improvement in spasticity of right upper limb and left lower limb after follow-up. The study group interventions were significantly effective in reducing the spasticity. The range of motion. The significant improvement in the study group in range of motion than in control group with the p-value less than 0.001. In the follow-up period, also sustained effects were noticed in the study group. So to conclude, it was stated that the combination of Mahamasha Thaila internally and the Mahasaindava Thaila externally is effective in reducing the spasticity in CP in children, and it was effective in improving the range of motion of joints and to improve daily activities. Moving on to the fourth study, the study titled Effect of Yoga Vasti to Reduce the Spasticity in Children with Cerebral Palsy in the age group 2 to 12 years, which is done by Dr. Divya TN under the guidance of Dr. Lashmi MK and Dr. Sohini in the year 2015. The study design adopted here was interventional study pre and post, and the study population children of 2 to 12 years of both the sexes, and sample size 10, study period 70 days, follow period 1 month. And the sampling technique here used was consecutive cases satisfying the inclusion and exclusion criteria. Inclusion criteria, clinically diagnosed cases within the age limit. Exclusion criteria, spinal cord lesion, neurodegenerative condition, congenital diseases, chronic illness like asthma, and children under anti-epileptic drugs. The study tool used here was for spasticity, modified Ashworth scale, and for the range of motion, goniometer were used, and also the grading of muscle power were done. For intervention, for Deepana Pajana, which is continued for the entire course of treatment except during Snehapana and Kashayavasti. For Deepana Pajana, Ashtachurna was given with 3 gram for 2 to 5 years, 6 gram for 5 to 8 years, and 12 gram for 8 to 12 years. Along with that, Ashtavarga Kashaya was also given 15 ml for 2 to 5 years, 25 ml for 5 to 8 years, and 35 ml for 8 to 12 12 years. And the Snehana was done for the next 3 days with Kalyana Grada, 5 gram for 2 to 5 years, and 10 gram for 5 to 8 years, and 50 gram for 8 to 12 years. And then Abhinga done with Dhanvantri Taila along with that Ushmaseda was also done for the next 3 days. After that, the Yoga Vasti was started. For Anuvasana Vasti, Dhanvantri Taila was used, and the Kashaya Vasti, the Panchamuladi Kashaya was used. Major findings within the group significant improvement in spasticity of all the 4 limbs, both after the treatment and after the follow up period. Improvement after follow up was significant, and the spasticity of upper limb 1 unit change for 7 patients and 2 unit change for 3 patients after follow up period, in which more changes in the right limb. And the spasticity of lower limb 1 unit change in 9 patients and 2 unit change in 1 patient for right side, and in left side 1 unit change for 8 patients and 2 unit change for 2 patients. The range of motion. The significant improvement had occurred after follow-up by goniometric assessment of all major joints. That is, the adductor angle show highly significant changes with the p-value less than 0.05. For popliteal angle, left side had more improvement. Dorsiflexion angle, both the sides have similar level of improvement. Heel to ear maneuver, left side had more significant changes. Shoulder joint, right side has got more changes. Elbow joint, left side more significantly got improved. Wrist joint, left side has got improved more significantly with p-value less than 0.05. The muscle power, all the muscle had not showed significant changes. Biceps of both the sides showed good improvements, and left side deltoid had more changes than the right side. The right side trapezius and the flexors of hip in both the sides were not shown remarkable changes after follow-up. The left extensor knee, right dorsiflexor, and the right plantar showed good improvements after follow-up. Reflexes, slight improvement in knee jerk and the ankle jerk, but not statistically significant. All other reflexes had not showed significant improvement. By this, it was concluded in the study that the combination of Dvipanchamuladi Yoga Vasti along with physiotherapy is found effective in reducing spasticity in CP and also improve the range of motion of joints. Moving on to the last and final study, the effect of 4 different treatment modalities of the application of Dhanvantri Taila along with physiotherapy as compared to physiotherapy alone in the management of spastic cerebral palsy, which is done by Dr. Devias under the guidance of Dr. Mini Muralidharan, which is conducted in the year 2018. The study design adopted here was comparative clinical trial and non-randomized control trial. Study population, children of the both sexes of the age group 3 to 12 years diagnosed with spastic CP. Sample size 20 patients, 10 in each group. Study duration 26 days. Follow-up period 30 days. Inclusion criteria, children of both the sexes of the age group 3 to 12 years diagnosed with spastic CP. Exclusion criteria, children with CP associated with cognitive diseases and genetic disorders, chronic respiratory diseases, neurodegenerative condition, other chronic systemic illness. The study tool used here was the range of motion of different joints with goniometer, spasticity assessment with modified Ashworth scale, the activity of daily life using Bartle's index. Intervention. The study group was given Abhinga, Vijana Stehapana, and Shirobiju with Dhanvantri Thailam for 21 days, and then Matravasti with Dhanvantri Thailam Medugubagam for 5 days, along with their physiotherapy was done. For control group, only physiotherapy was done. Statistical analysis. For qualitative parameters, Wilcoxon sign rank test and man-Whitney U test were used. For quantitative parameters, pair T test were used. Major findings on analyzing the social demographic data, 35% cases belongs to 8 to 12 years and 65% cases belongs to 3 to 7 years age group, in which 55% were male and the 45% were females. And also 55% of the participants were underwent normal delivery, 35% underwent LSES, 10% forceps delivery, and 5% vacuum delivery. Antenatal history. 25% of the case having the history of infection, 5% having the history of trauma, 25% having low birth weight babies, 15% having very low birth weight, and 35% having delayed cry after birth. Spasticity. Between group comparison, both the group were equally effective. Within the group, highly significant in the study group than the control group with the p-value less than 0.01. The effect after the follow-up period was sustained in the study group than in control group significantly in all limbs except left upper limb. Significant improvements were noted in the right upper limb and the left upper limb after follow-up. The study group intervention were significantly effective in improving spasticity than the control groups. Range of motion. Significant change occurred in the study group than control group after the treatment and after the follow-up period in adductor angle, popliteal angle of both sides, right wrist angle, right elbow, and the right shoulder angle. Sustained effect after follow-up period more in study group, especially in left dorsiflexion angle, left wrist angle, right elbow angle. All the other angle has not showed significant effects on comparison. Then activities of the daily living. In between group, in personal hygiene and the toilet training, significant change in the study group after treatment and after follow-up period. And the highly significant changes after follow-up, such as feeding, dressing, bowel control, and ambulation, and the sustained effects were significantly improved in the study group than the control group. So these findings suggested that the administration of these four procedures such as Abhyanga, Vijayana Sehvana, Matravasti, and Shiropiju, along with physiotherapy, had more effectiveness than physiotherapy alone in spasticity in the particular age group. Thank you.
Thank you, Dr. Sankita. You shared full of interesting facts, rich in contents. Now the session is open for discussions. Delegates, please note that you can unmute yourself to ask questions or type the questions in the chat box if you prefer. Any further questions? I hope no more queries left. Thank you, Dr. Sankita. Now, we are about to wind up today's scientific session. Tomorrow, we will continue with another thought-provoking session by Dr. Arathi Ji, Assistant Professor, Department of Kaumara, Government Ayurveda College, Trivandrum, on the topic Physiotherapy and Orthotics in Cerebral Palsy. And next session by Dr. Lakshmi and Menon about recent advancements in cerebral palsy. Hope you all enjoyed today's session. Thank you for being with us.